My name is William Moss, and I'm the Executive Director of the International Vaccine Access Center here at the Johns Hopkins Bloomberg School of Public Health. And it's my great pleasure to moderate today our World Immunization Week webinar titled A Lifetime of Protection, the Impact of Vaccination Across the Life Course. And four of my colleagues from the International Vaccine Access Center are joining us today to give you an overview of some of their work about vaccination across the life course. We'll hopefully have time for questions at the end, as Tori indicated. But what I'll do now is briefly introduce or tell you about our four speakers today, and then we'll jump right into the program. So our first speaker is Dr. Andrea Carcelin. She's an assistant scientist here at IVAC in the Department of International Health, and her work focuses on supporting immunization programs to reach vulnerable populations through innovative surveillance of vaccine preventable diseases and mixed methods research on improving vaccine uptake, with a focus on countries in Latin America and Africa. Andrea's recent work has focused on multi-pathogen serosurveillance to guide immunization and disease control programs and strategies to make measles and rubella vaccination campaigns more effective and efficient. Our second speaker will be Dr. Chizoba Winodi. Dr. Winodi is an associate scientist here at IVAC in the Department of International Health. She is a public health physician with expertise in immunization program delivery, implementation science research, behavioral science, and primary healthcare development. Dr. Winodi has nearly 30 years of experience in public health, and her most recent work focuses on deploying and evaluating childhood, adolescent, and adult vaccines in Nigeria, Kenya, Ethiopia, Tanzania, Madagascar, and Haiti. Our third speaker is Dr. Molly Sauer. Dr. Sauer is currently a postdoctoral fellow here at IVAC in the Department of International Health. And Dr. Sauer has been an integral member of IVAC for over a decade, having served as Scientific Policy and Communications Officer and Deputy Director for Policy, Advocacy, and Communication. Dr. Sauer's current work includes evaluating the rollout of a measles IgM-RDT and the R21 malaria vaccine in Zambia, as well as working closely with Dr. Carcelin on optimizing measles and rubella campaigns. Our fourth and final speaker will be Dr. Sean Truelove. Sean is an associate research professor at IVAC in the Department of International Health with a joint appointment in the Department of Epidemiology here at the Johns Hopkins Bloomberg School of Public Health. He studies how to predict, respond to, and prevent outbreaks and epidemics through the use of infectious disease epidemiology, disease dynamics, and modeling. So first we'll go to Dr. Andrea Carcelin to talk about her work on reaching unvaccinated children. Andrea?
Thank you, Dr. Moss. And thank you all for being here today. You can go to the first slide, Tori. So just briefly by way of introduction to mention that the Expanded Program on Immunization, or EPI, was launched over 50 years ago to ensure that all children benefited from life-saving vaccines. And today, every country has a national immunization program, which many use diphtheria, tetanus, pertussis, or DTP containing vaccine as a metric to monitor the program's success. So you can see here, this is a graph of global DTP1 coverage, and DTP3 is also depicted in the light blue below. And it's remained fairly steady in the recent past until COVID-19, which caused a dip in coverage in 2021, which you can see by that top arrow highlighted there. Since then, there have been global efforts, including a big catch-up campaign that have really worked to help restore coverage. And while it's not quite reached its pre-pandemic levels, it is improving. In 2024, it's estimated that there are about 14 million children who remain zero-dose, meaning they have not yet accessed the routine immunization system. Next slide. Children have several visits throughout infancy, and this often culminates in the receipt of measles-containing vaccine at 9 months and 18 months. Coverage for these vaccines tends to be lower than for DTP because they're given later in life. And so you can see that there have been great strides in improving coverage for measles vaccine, particularly the second dose, which you see in the orange line across the graph. Like with DTP, the arrow is pointing to a dip in the first dose of measles vaccine that happened during the COVID-19 pandemic. The bottom arrow demonstrates how there are still 20 million children globally who have not received any measles vaccine and remain at risk for measles, particularly now as cases are on the rise. And these estimates come from WHO UNICEF estimates. Next slide. So to better reach the children that are typically missed in the routine immunization program, many countries use nationwide non-selective vaccination campaigns. These are often resource intensive, require external funding, and can be disruptive to the healthcare system. Moreover, they often end up revaccinating many children who've already received 1 or 2 doses of measles vaccine. So there's a global push to consider if there are alternative supplemental strategies that might better reach measles un- and under-vaccinated children. And to do this, countries are seeking guidance on how to either better tailor their vaccination strategies or their campaigns. Next slide. So to explore this, a team at IVAC conducted a scoping review of what strategies other than vaccination campaigns have been used to better reach un- and under-vaccinated children. We found that these tended to fall into the categories of demand generation in orange, human resource initiatives in green, supply chain improvements in blue, and then the service delivery modifications in the purple all the way to the right. And these included different types of initiatives, such as child health days and periodic intensification of routine immunization, or PIRIs. Next slide. We then went on to holistically evaluate how some of these measles vaccination campaigns were being tailored in a few different settings. We did this by conducting in-depth interviews and focus group discussions with decision makers to think about how they're deciding what type of campaign they want to implement. Then we did direct observations and additional interviews with those who were actually implementing the campaign through process evaluation. And we supported the post-campaign coverage surveys and did reanalyses of the data to look at what the impact of the campaigns were. Finally, we looked at the costing and compared how those strategies differed based on the campaign. Slide. So we did this in 4 different countries that each used a different vaccination campaign strategy from 2024 to 2025. Briefly, Rwanda in the top right here is a country with pretty high measles vaccination coverage. And so they opted to target their campaign geographically, implementing their measles vaccination campaign only in the districts that had the lowest coverage. And they aligned this with their maternal and child health weeks, so that in the districts that were not implementing the campaign, there was default or tracing occurring at the same time. In the bottom right, you see Zambia, which conducted a more traditional nationwide measles vaccination campaign. And then we're going to talk a little bit more in depth about the remaining countries, Madagascar and the Gambia, who both integrated routine immunization catch-up activities into their measles campaign. Next slide. So in Madagascar, it's a country with low routine measles vaccination coverage. You know, we're going quickly, but in the previous slide, we saw that they have about 50% coverage for their first dose of measles vaccine. So they opted to integrate a campaign to deliver measles vaccine, oral polio or OPV, and routine immunization catch-up activities. This integrated strategy allowed them to reach many un- and under-vaccinated children, but had some implementation challenges because of the complexity of delivering so many vaccines simultaneously. They had some confusion around some of the catch-up vaccination policies based on the age of the children, the data recording of all these different vaccines in a high-paced setting. And the caregivers tended to have a preference for oral vaccines rather than injectables, making social mobilization more complicated. The campaign was quite successful, though, and this can be attributed to having double the number of teams that they typically use, which allowed them to do a more block-to-block strategy. So OPV or polio campaigns often go house to house to deliver vaccines, but measles vaccine campaigns have traditionally set up fixed or outreach posts. And this requires caregivers to bring their children to the vaccination post. This is done due to logistical challenges of an injectable vaccine that has to be reconstituted. But the block-to-block strategy allowed them to do a more pushed approach to meet people where they are. They couldn't quite go house to house, but they were going neighborhood to neighborhood, which allowed them to be much closer to the community, and they were very receptive of the strategy. And you can see in the photos on the right that this required kind of massive operations in terms of hundreds of healthcare workers at every facility, many cold boxes, and lots of coordination to get this off the ground. Next slide. The Gambia similarly did an integrated campaign, but they delivered vitamin A and mebendazole or deworming, along with the measles campaign, and then also did a PIRI to deliver routine immunization to kids who might have missed it during the pandemic. They similarly used an intensified block-to-block strategy focused in the urban areas because this is where they have the highest number of zero-dose children. Similarly to Madagascar, they found that this push strategy of meeting children where they are was quite successful. And to better facilitate the operationalization of this, they used vaccination hubs in the community, which are these large coolers that could serve as refrigerator for the duration of the campaign. And you see a picture in the bottom right here. This meant that teams did not have to go all the way back and forth to the health facility at the beginning and end of each day. Next slide. So that's all about kind of how the campaign was implemented. And now to think about what the impact of the campaign was. Traditionally, campaigns have been evaluated by whether or not they reach a 95% coverage threshold. But this masks the true value of campaigns because they often revaccinate children who were already reached through the routine immunization system. We depict this in these three bar graphs by the dark black or gray on the left-hand side. The light pink are kids who received a second dose of measles vaccine through the campaign, and that dark or bright pink are those who were zero dose before the campaign and received their first dose of measles thanks to the campaign. And the light gray bars all the way to the right represent the children who continue to be under-vaccinated. So here you can see that across these countries, 20 to 40% of children are receiving their necessary measles vaccine doses through the campaign. Next slide. Another way to think about evaluating the campaign is how efficient it was, or how many children had to be vaccinated in order to reach one unvaccinated child. So for example, in the Gambia, you can see that for every 18 children that you vaccinated during the campaign, one, represented by that red person, was an unvaccinated child. This is because they have high coverage. Whereas in Madagascar, where there's low measles vaccination coverage, for every 3 children you vaccinate, you're reaching one child who would not have been vaccinated through the routine system. This highlights the need for more targeted approaches in a country like Gambia. Next slide. And finally, to touch on the cost. It should be noted that the hardest to reach children that require a more innovative strategy to get to them is likely to be the most expensive. So we looked across the countries to see how much it costs to reach a zero-dose child. And you can see that where there were fewer zero-dose children, like in Gambia, it's much more expensive. Versus in Madagascar, where there are many more zero-dose children, it's cheaper to reach as zero-dose children. And the pictures just represent some of what those hard-to-reach areas might look like. Next slide. So just in summary, there have been substantial global efforts that have gone into restoring vaccination coverage back to pre-pandemic levels. To protect children from measles, alternative vaccination strategies are needed to meet them where they are. We talked today about block to block and how that allows campaigns to really go out into the communities. Other initiatives that we've implemented include school entry vaccination checks, because school enrollment has become higher and higher in many countries. And this allows for catch-up and screening to occur when they come in to schools. Similarly, screening can be done when children come to health facilities, either accompanying family members or when they come for sick visits to see if they're up to date on their vaccines. Catching children at every potential interaction can help to reduce the number of unvaccinated children. Thank you.
Thank you very much, Andrea. We're going to move on in the interest of time to our next speaker, Dr. Chizoba Winoti. And Dr. Winoti is going to speak to you about her work strengthening HPV vaccination and adolescent health research program project in Nigeria. Chizoba?
Thank you very much, Dr. Moss. Next slide, please. Okay, thank you. So the context of this study is in Nigeria. Nigeria introduced the HPV vaccination in 2023 and 2024 very successfully. More than 30 million girls were vaccinated, girls 9 to 14-year-old. However, after the campaign introduction, routinization has become a problem, has remained a problem due to service delivery and demand side issues. So effective strategies to reach adolescent girls, especially girls who are vulnerable and out of school, are needed. This study was to examine or explore how integrating HPV vaccination with other adolescent health services could improve uptake of HPV vaccination and other adolescent health services. Our study objectives were first to co-create an adolescent health service that's integrated with HPV vaccination. Secondly, to test the feasibility and acceptability of implementing the integrated package. Thirdly, to assess the effectiveness of that integrated service package on HPV vaccination uptake, adolescent health services, as well as knowledge and attitudes. Now, the study was done in Kebbi State, Nigeria, in northern Nigeria, as well as in Lagos in southern Nigeria. It's a quasi-experimental study, mixed methods with both qualitative and quantitative data collection. And the activity started from March and ran till December. In March, we had human-centered design workshops where we worked with adolescents, health providers, teachers, and other stakeholders to actually design this integrated model of service delivery. Then in April and May, we did our baseline data collection. June to October, we ran the intervention. November to December, we had our end line. So today, I will present data from the study. Next slide, please. So just to let you know how the service was delivered, we had fixed posts, community outreach, school outreach, mobile services. These were services that were implemented by vaccinators, and they provided to adolescents education, cervical cancer education, HPV vaccine education, menstrual hygiene, as well as HPV vaccination for 9-year-old girls who are the eligible girls for HPV vaccine in the routine system. We also provided albendazole, as well as sanitary pads, bathing soaps, detergents, wristbands, and lapels. These were the items the adolescents said they wanted integrated with the HPV vaccination. In addition to that, we also integrated within HPV clinics as well as life planning clinics in Lagos, cervical cancer education and HPV vaccination information, as well as referral to the health facilities for HPV vaccination. So no vaccination took place in these non-immunization settings. Next slide, please. So here are some results. These first few results will be from the routine administrative data. Next slide. So after 5 months of implementation in Gwandu, which is the intervention LGA in Kebbi State, we see that the weekly trends in the number of HPV vaccination increased. On the left panel, top left panel, is the trends, weekly trends, and you can see that the dotted line indicates when our intervention started. The orange line indicates the weekly trends in Gwandu local government area, which is our intervention LGA, and then the blue line indicates trend in the comparison LGA, Dandi local government area in Kebbi State. In Kebbi as a whole, we vaccinated more than 14,000 girls, and this represented 84% of the approximately 17,000 target number of girls that we estimated in our intervention LGA. In Kebbi State, 65% of girls were in school, 35% were out of school. And most of the vaccinated girls received the full complement of the integrated service delivery. Next slide, please. In Agege, in Lagos State, Agege was the intervention LGA in Lagos State. We also see that from the dotted line onwards, there was also an increase in the number of vaccination offered to girls weekly. Before the dotted line, you can see two spikes there that represented a campaign that was implemented by the Lagos State government before our intervention. After the campaign, coverage went right down, and then with our intervention, you can see that there was a higher vaccination, weekly vaccination in our intervention LGA, which is in blue, than in a control LGA that is in orange. In Lagos, we vaccinated a total of more than 7,000 girls, and in Lagos, 98% of the girls were in school, while only about 2% were out of school. And most of the girls received the full complement of the intervention package. Next slide. We conducted household surveys to look at HPV vaccine coverage amongst 9-year-old girls. What did we find? We found a mixed effects of the intervention on HPV vaccine coverage. In Kebbi State, there was a significant positive impact of the intervention. You see coverage rising from 9% in Gwandu, the intervention, to 53% at Endline. In our comparison, there was an increase, but it was from 13% to 33%. And when we looked at the difference in difference, that was statistically significant. So relative risk was 2.39% difference in difference. Now, in Lagos, we were not able to demonstrate any improvement in coverage in both the intervention and the control LGA. Next slide. We found a positive effect of uptake of additional adolescent services in both Kebbi and Lagos State. So you can see the improvement in Gwandu from 22 to 41%, in Agege from 20 to 50%. And this was corroborated by qualitative data from the girls. Here, a girl is noted as saying, they gave us clean detergent, sanitary pads, and deworming medicines. Next slide. The intervention had a mixed effect on knowledge, attitudes, and norms. While all the point estimates asking about change in knowledge and positive attitudes as well as subjective norms are trending in a positive direction, only attitudinal change in Lagos, which was positive, was statistically significant. Next slide. So the intervention was found to be acceptable by girls in both Lagos and Kebbi states. And here, there's a quote from the program manager that says, with sharp intervention, the sanitary pads, wristbands, and the warming tablet really helped acceptance in acceptance of the vaccination in the community. Next slide. Adolescents also perceived this intervention to be feasible, to be implemented in the routine program as well as in schools. You can see at baseline, perceived feasibility was high, but it also increased in our intervention LGAs in both Lagos and Gwandu State. One thing to note here is that it's important for particularly the school-based delivery to involve the teachers. A quote here from Gwandu says, "The teachers supported us by mobilizing their students through a roll call, ensuring that students within the required age take the vaccine." Next slide. So here are the summary of our findings. We found that there were positive vaccination trends from routine data. We found positive impact on vaccination coverage in Kebbi State, uptake of additional adolescent services in both states, improved knowledge in Lagos State, improved acceptability and high perceived feasibility of the intervention in both states. Next slide. Some of the key challenges related to limited health workforce. So in Lagos, we had to hire additional ad hoc staff in order to conduct the school outreaches. In both Lagos and Kebbi, we also faced demand challenges. So there were some parental hesitancies. There was also difficulty accessing private schools and a requirement that we provide written consent for girls to be vaccinated. And then the school calendar, exams, holidays disrupted our research activities. And then there were also some environmental barriers or challenges. Rainy season affected mobility of both the researchers and the health providers. In addition, in Kebbi State, insecurity ruled out access to certain communities. Next slide. So the key lessons here really are that, number one, for Lagos, for Kebbi particularly, we did a micro census that gave us a better idea of the target population, and so we were able to reach them. So we need to have good target population in order to be able to reach all the girls, particularly out of school girls. We need to co-design the interventions with the end users, the adolescents. We need to integrate with the educational sector to ensure that our interventions are sustainable. Last slide. So in terms of consideration for scale up, the key thing is really institutionalizing the integration within routine platforms, be it the health facilities or the schools. Investing in frontline health worker capacity and quantity. Developing micro plans that are based on accurate target population. From the governance perspective, we need to really strengthen multi-sectoral coordination and then ensure that there's sustainable financing for these activities, because the parts have to be bought, outreaches have to be paid for. And then for the demand generation, it's really important to prioritize engagement with the community and to have community leaders as champions. And lastly, we need reliable data systems in place in order to ensure that we're monitoring right and identifying where gaps exist. Thank you.
Thank you very much, Dr. Chizoba. That was excellent. So we're moving through the life course, and we've gone from children to adolescents, and now Dr. Molly Sauer is going to speak to us about her work on maternal immunization. Molly?
Thank you, Bill. Yes, I'm so thrilled to be talking about maternal immunization today, which is a really unique opportunity for us to provide 2 rounds of protection, keeping moms healthy and safe during pregnancy and keeping babies healthy and safe at delivery in the first weeks and months of life. So let's jump into this. Thanks, Tori. So just to get us on the same page, it's really important we understand what maternal immunization means and how it differs a little bit from some of the other vaccines and vaccination strategies we've been talking about today and will continue to talk about. Pregnancy is a very complicated phase. It's very complex. There's a lot happening, and we are able to take advantage of that complexity to provide this dual protection. So why do we care about vaccinating in pregnancy? Pregnant women are often at higher risk of getting sick in the first place and having more severe disease outcomes when they do get sick. So we are dealing with a condition where women are at greater risk of serious illness. But on top of that, they're often less able to access some of the treatment and diagnostic strategies that we use in non-pregnant individuals. So the benefits of maternal immunization in this space is to step into this complicated stage and try to provide protection that helps mom while she is pregnant, but also lets her leverage that incredible biology going on to pass her antibodies on to the developing fetus and provide some early protection, again, in those first weeks and months of life when baby's own immune system is still developing. It's not quite ready for prime time. But it's also at high risk of getting serious illnesses like RSV, among others that we'll talk about today. And the way that works is that mom's antibodies are passed through the placenta or through breast milk. So there's three sort of groups that we can think about when we talk about vaccination in pregnancy, just to, again, try to understand how this fits into our broader portfolio. We vaccinate in pregnancy to protect newborns and young infants. This, again, is an age when they're very susceptible to infection and to serious outcomes. So maternal immunization passes those antibodies from mom to the developing baby and provides that early protection. Some vaccines that you're probably familiar with in this age group or with this priority in mind are things like tetanus and pertussis containing vaccines, new RSV vaccines given in pregnancy, and upcoming Group B streptococcus vaccines. So these are, again, diseases that are of particular concern for pregnancy, that point of delivery, and those first weeks of life. We also want to think about pregnancy as its own risk factor. So making sure mom is protected so that she can have a healthy pregnancy and pass, again, that protection onto the baby. Often in routine systems, we're giving things like influenza vaccines in pregnancy or more recently COVID-19 vaccines, again, to protect mom and help protect baby. And then there's a third group that's helpful to keep in mind that there are some vaccines that aren't part of our routine program, but might be used in the case of an emergency or an outbreak. These are usually conditions that are especially serious in pregnancy. They can be highly fatal in that group. And so we want to make sure that pregnant women have access to vaccination in the case of an outbreak. Probably the most visible of these is the Ebola vaccine that has been under use in pregnant communities now. But recently, we've also seen Mpox vaccines used in pregnancy for this purpose. Next slide. So I've mentioned a couple different vaccines so far, some of which you've probably heard about or thought about in pregnancy, but some that may be newer. And that really speaks to the variety of engagement we have around different parts of our vaccination portfolio and how they are or are not used in pregnancy. On the far left, you can see here there are 5 core vaccines that are recommended in pregnancy and are given routinely, depending on the context where the pregnant person lives. So in higher income countries, we're often seeing all of these vaccines given. In low and middle income countries, where I'll focus the rest of the talk, it's really just a handful. Tetanus vaccines, for example, have been in use in pregnancy since the 1980s. So while we have a lot of emerging evidence and opportunity here, vaccination in pregnancy is not a new concept. We also have a really exciting pipeline underway for maternal immunization, with Group B streptococcus vaccines on the way, research undergoing for CMV and new malaria vaccines, Zika virus, and many others. So there really is a broad range that we're thinking about how best to meet pregnant women where they are and provide the protection that's tailored towards their needs in this phase and in their geographies. Next slide. So I'm going to spotlight a little bit of data coming out of the extensive Maternal Immunization Readiness Initiative, or MIRI, which for the last several years conducted demand and readiness studies in a number of countries, Kenya and Bangladesh for COVID-19, RSV, and GBS vaccines, and then a broad study on COVID-19 vaccination and pregnancy in Brazil, Ghana, Kenya, and Pakistan. And we'll tie this into some other work on other projects, but if this is an area of interest for you, I'd encourage you to check out the TechNet page that lists out all of the data and publications coming out of this work. Next slide. So what the maternal immunization work under MIRI and some partner projects has tried to do is to understand In this context where we have new maternal vaccines coming into availability, but we know that there is a window before they're likely to reach low and middle income country populations, what can we learn or better understand now so that we can equip systems, providers, and communities to be ready to make those decisions about whether to receive a vaccine in pregnancy or not? And so you can see here a range of the different factors that come into play when making a decision on maternal immunization. A pregnant woman's choice to be vaccinated during pregnancy is not only about her own knowledge and attitudes, but it's affected by her friends and neighbors, by her trusted provider, or how she's engaged with the health system before. And that moves all the way up to a policy level where we want to see if there's relevant information or evidence to shape a program. Is there a Ministry of Health recommendation? These influences cascade in both directions. That enabling environment affects that pregnant mother's decision making, but her willingness to think about this and to consider vaccines in pregnancy also helps shape Ministry of Health and broader partner decisions about what vaccines to investigate and how to shape recommendations and introductions. Next slide. So I'll take you through just a couple quick snapshots here, but we'll start with some of the larger barriers and enablers that emerged through this study. To keep with the theme of the day, this was a mixed methods analysis. So we were conducting interviews and focus groups with pregnant and lactating women, their communities and partners, their providers, and then the policy and program officials who shaped those services that they were able to access. And we also conducted surveys and some additional engagement to shape dissemination strategies. I highlight here a few of the emerging themes that we saw across the study that are really critical for maternal immunization. Some of these are not unique to maternal vaccines. We hear about questions on social norms, about misinformation, trust in providers, and trust in the information being received across many vaccines. But just to spotlight a few that are really striking for maternal vaccination. The first is diseases like RSV and GBS unfortunately bear the burden of being a bit indistinguishable from a number of other syndromes. So you can see here that even the language that's being used to talk about an RSV case can really be varying by the community and by the key stakeholder who's engaged. Not everybody has heard of RSV or understands what it is in this context. So when we're dealing with diseases that are hard to distinguish from others, it really affects individuals' risk perception and their willingness to be vaccinated or to seek out services like this. We also struggle from challenges where the disease is affecting someone. So children visiting a pediatrician is where you will see a case, but that's not where a child would be affected by vaccination, right? Their obstetric or gynecologist is going to be the person who's actually having a conversation with a mother about vaccination. And then this persistent question about why only in pregnancy continues to be a key question here. What is exceptional about pregnancy that makes people most suited for vaccination for these diseases? What sets them apart? Next slide. In addition to talking to mothers, pregnant women and lactating mothers, we also explored how providers perceive maternal vaccines. And here we looked especially at the pipeline. Vaccines that are not yet ready to reach availability, especially in low and middle income countries like GBS. How are healthcare workers navigating these questions? And what kinds of issues do they foresee for their communities that we could perhaps preempt? Unsurprisingly, as you can see here, side effects and safety for vaccination in pregnancy continue to be the top concern that we hear, which means we're really ready to start addressing those questions and to make sure that information about safety is at the forefront as we start to launch maternal vaccines. Next slide. But so while we've explored what communities think and feel about maternal vaccination and how providers are readying themselves to navigate it, how those decisions are made for future vaccines in pregnancy can really be affected not only by those views, but by the broader context. You can see here some results from questions around what future maternal vaccine would you be most interested in receiving or would you prioritize access to? And so pregnant women in Brazil, Ghana, Kenya, and Pakistan, as you can see, had really varied responses. I like to highlight especially Ghana, where we saw that malaria was by far the top priority for a future maternal vaccine. And so it really hinges on what people are familiar with, what's visible to them, and how severe those visible conditions seem to be relative to others that they may be less familiar with. This cascades up to the policy level. So if you go to the next slide, under our Choices initiative, we also explored how country decision makers make these choices of which vaccines to introduce, which vaccines to switch, and how to navigate these really complex portfolio decisions in the face of really limited resources and timelines. And as you can see in the light blue line towards the top, the maternal RSV vaccine introduction in the context of a range of other decisions about EPI programs was consistently at the top. It is a complex choice with a new population. It requires new touch points. It doesn't fit cleanly into an EPI schedule. It requires interacting with antenatal care as well as EPI, which means more resources and more effort needed to explain to communities and providers why they should prioritize this themselves. Next slide. So just to wrap up, a lot of the work has been aiming to ready systems and structures to prepare providers and to sensitize communities so that we can really have more effective demand generation. We can answer questions ahead of time, and we can shape systems that are ready to monitor new vaccines in pregnancy, especially in the settings in low and middle income countries where they are most needed. Thank you so much.
Thank you very much, Molly. Your presentation kind of closes the loop on the life course by protecting not only the pregnant women but their infants. So we're going to conclude the presentations with Dr. Sean Truelove, and he's going to talk about adult vaccination, building evidence for decision making in the United States. Thank you very much, Sean.
Thanks, Bill. Yeah, so today I'm just going to talk a bit about some of our work where we're using infectious disease modeling to try to build some evidence for decision making in the U.S., working with partners that are trying to make the best decisions around recommendations, around supporting vaccines, and then touch a bit on how we can learn from this for other settings. So we've talked a lot about vaccination over the life course, and a lot of the vaccination work that we do, and when we think about vaccines, we really do think about children. But it's really important to remember and touch on just how many vaccines there are that are critical for adults as well, and how much impact those diseases have on our adult populations. And as you can see here, some of the top ones are ones you might think of: influenza, COVID-19, pneumococcal, but there's a number of other vaccines that are critically important to limit burden across all ages as well as adults. For today, I'm going to focus mostly on COVID, influenza, and RSV. And really, I wanted to touch on this to start. So despite us, being past the pandemic, moving into, normal reality and not really thinking much about COVID as much as we can, we have to reflect on the fact that COVID still does cause a substantial amount of mortality and morbidity. These are numbers from the US, where we have pretty substantial surveillance to continue monitoring these things. But what we see is a decline from what was quite extreme compared to other respiratory viruses, down to a level this year, and this is preliminary data here for 2025 to 2026, of about 13,000 deaths caused so far. So these numbers will go up, but that puts us right in the range of influenza. So despite a comparison to what we were previously experiencing in the last couple of years, feels like COVID is gone and we don't care, it still remains a very substantial cause of death in the US, as well as in many parts of the country, or many parts of the world. And on top of that, we are facing new challenges with continued and growing vaccine skepticism, challenges to access vaccines, challenges against recommendations that are making this even more of a problem and something that could grow as an increased source of burden of disease. So how do we deal with this? Well, one of the things that we have been doing over the last many years is to try to generate robust evidence to support these decisions. And we have established what's called the Scenario Modeling Hub to do just that. And so this is an effort to generate robust consensus-driven scientific evidence through well-defined multi-model scenario projections. These efforts really do aim to directly address critical decisions that are trying to be made from key partners, providing exactly the evidence that they need to say choice A versus choice B. And we do that through scenario projections, which is what this figure shows on the far right. Just as an example of one of the rounds that we've done previously, this was a round in 2023, projecting the impact of various vaccination recommendations, whether we continue to vaccinate everybody in the US population for COVID-19, whether we just focus on those 65 plus or get rid of COVID vaccination completely. And what we found was pretty substantial continued value of vaccines, right? We see in these figures here, getting rid of vaccines would have increased our hospitalizations by about 500,000 in the US for that season. Actually, that was a 2-year period. It would have led to an additional potentially 50,000 deaths across the US. Whereas just focusing on the 65 and up, we continue to prevent a substantial number of deaths, but the difference between the just vaccinated 65 and up versus everyone provides about 20,000 deaths saved and 200,000 hospitalizations saved. And so this specific evidence that we produced went straight to ACIP and helped them with their evidence base for making the decision to continue to support vaccinating all population or all ages in the US. So we're continuing this work. This past season, we focused again on vaccination, focusing similarly on the same question of no recommendation, no vaccination, only recommendation for high-risk groups or vaccination for all eligible groups, once again. And then we also focused on vaccine timing. Should we be thinking about timing that is not the timing that we have now, which is aligned with influenza vaccination? But I'm not going to focus on that right now. But what I do want to touch on is our key results from this, and that is that all vaccine strategies continue to have significant value and reduce disease burden in the US. We also find that there continues to be expected burden from COVID-19, as I just showed, and we expect this to continue for several years to come. And a lot of this burden, most of this burden, is concentrated in adults, particularly those age 65 and up. And we also found that indirect and direct effects are really important to limit burden, right? Vaccinating everyone versus high risk only saves about 26,000 hospitalizations in the US through those indirect effects of reduced transmission. So turning from COVID to influenza, in the face of these vaccine challenges and the skepticism challenges, we continue to want to support those decisions and that communication that vaccines are important for influenza as well. And so we have been doing rounds for influenza over the past few seasons as well, demonstrating the importance of continuing to maintain this coverage. And as you can see in this top figure here from the CDC, we are seeing a substantial drop in influenza vaccination post COVID-19. And the impacts of this could be substantial, right? If we look at the results for the usual vaccination, so where we are now versus a lower version of that, we see about 55,000 hospitalizations that are not being prevented if vaccination drops to a lower level. So these data are really critical to provide the direct evidence for decision making and help people make the right decisions with this with their own choices, as well as help public health institutions to support their recommendations. Now, we also are seeing, of course, new vaccinations with RSV coming in, and then others with dengue and malaria coming for the future, that there is going to be continued great impacts among adults now and in the future. With RSV, we've talked a lot about infants, but we do see substantial value among the older adults. And from our results from the RSV Scenario Modeling Hub, we found that RSV adult vaccinations in the US demonstrate similar impacts to those of infant vaccines in the US as well. We have rounds underway for this season. New partnerships are being established to ensure there's value for the US Scenario Modeling Hub. Please check out our website. And this is an immense effort from a number of partners that I really can't thank enough for all their dedication to it.
Thank you very much, Sean. And so what we'll do is, I'll just welcome anyone to put any questions in the Q&A. But maybe I'll ask some questions just to get us started for the next few minutes. I'll go first to Dr. Carcelin. So, Andrea, you talked about kind of ways to better reach unvaccinated children, and I think we all know that global funding for global public health and for vaccinations is kind of has diminished, and so countries are going to have to do more with less. Could you give us just a few insights on how countries should be thinking about, reaching these zero dose children with perhaps less funding?
Sure. Thank you, Dr. Moss. Yes, I agree. There will certainly be more challenges going forward with the decrease in global health funding. But some of the things that we talked about today about really doing a more targeted approach. So if it is going to cost you more to reach those unvaccinated children, right, then sort of focus your efforts on the areas where those unvaccinated children are concentrated, as opposed to kind of blanket, doing a vaccination campaign across an entire population is one strategy for countries that are able to do that. The second I would say is the approach that we talked about with Gambia and Madagascar, and we're currently working on those estimates now to think about what was the cost savings that were able to be found by integrating, right, the measles vaccination campaign with the polio campaign, or with vitamin A deworming, or with routine immunization. And it was found that, for the most part, the community is very receptive to that type of approach, because if you're coming to their door and you're bringing services, often they're tired of the multiple polio campaign rounds that have happened, and so they welcome the opportunity to get some of these other services to their children.
Great. Thank you, Andrea. So the next question, maybe it's for Molly, but so this is from Ellie from the Jakarta Post in Indonesia, asking about what vaccines need to be recommended for women in pregnancy. Maybe you could start with that one.
Sure, thanks. And yeah, it's a great question and a complex question. I think, as you saw on the slide, we have a huge range of vaccines available for different points across the life course, and as we've talked about today. And there are some pretty consistent recommendations for those core routine vaccines necessary in pregnancy. We talked about pertussis and tetanus. Tetanus has been essential in eliminating maternal and neonatal tetanus transmission in many areas. So we've seen the progress that maternal immunization can make. I think a lot of times we talk more about the variability in those recommendations and how context specific it can be. So if you kind of reflect back, there's a large box there of vaccines that are permitted in special conditions or under special scenarios. And what that really speaks to is the assessment of risk in pregnancy and the potential disease severity and susceptibility for a pregnant woman in a given setting, or with given conditions of their own underlying the pregnancy, that might shape which vaccines they are in need of, and which might be options on the table for them. So I would defer actually to my clinician colleagues on the call to go into the specifics of recommendations in the spirit of one thing that has come through time and time again on maternal immunization is how essential it is that pregnant women trust their providers and feel like they can have these conversations about which vaccines they need in pregnancy and which ones might be beneficial, and can grapple with those decisions in real time with someone who can meet them where they are and speak to those values. I do see also, I want to note that you highlighted remote areas as an especially complicated space for maternal immunization in Indonesia. And I think that has also been really resonant. Um, to be vaccinated in pregnancy, you need to be able to access antenatal care on the schedule that aligns with when that vaccine needs to be given. And we know that antenatal care access can be really variable, especially in more remote or hard to reach areas, conflict affected or fragile settings, and in migratory populations. So those are all places where I agree we need to have a concerted effort to figure out how best to make maternal immunization a convenient choice that pregnant women can access to help protect themselves and their babies. And I'm eager to learn more about the specifics of how that looks in Indonesia. So thank you for your question, Ellie.
Thanks, Molly. I'm going to see if we can get two questions in. I'm first going to turn to IVAC Senior Advisor, Matu Santosham. If you can ask your question. I don't know if you can unmute. Um,
It may need to be typed into the
oh, it
chat.
needs to be
Yes,
typed in,
I
Matu.
believe so.
Okay, yeah. Then while Matu's doing that, I'm going to turn to Chizoba. There was a question on what are the biggest cultural variables you have encountered while conducting data collection? And if you could give a brief answer to a complex question.
Yeah, that's a complex question for sure. Um, I think in terms of culture, when you think about Northern Nigeria, for example, we have to take account of the the culture that women, or rather men, cannot enter homes where they cannot enter homes where there are women. So strange men cannot enter homes. So when we have data collection happening in Northern Nigeria, we make sure that we pair the data collection teams, a man and a woman, so that they can have access to interviewing women. So you can have two men go into a community or go into a home to do interviews. So that's one example of how you need to understand the culture and then design your data collection appropriately, accordingly. Another key thing we see in terms of culture is for this particular study, we interviewed both adolescents and their parents, right? And so culturally, and also even ethically, you can't just go and interview adolescents who are minors. You have to obtain permission from their parents. It's not enough to obtain permission from their parents to interview the adolescent. You also have to obtain assent from the adolescent. Now, in northern Nigeria, you can find minors, that is girls who are less than 18 years, who are married. So those minors are called emancipated minors. And it means that you have to also have a specific approach towards interviewing them. It might be that who you get permission from to interview the minor is the husband rather than the parents. So these are some of the considerations that come to mind when you are doing, at least for this particular study that we did, but there are several more.
Great.
Yeah.
Thank you very much, Chizoba. Well, we're a minute past the hour, so I want to thank our speakers for today, and I want to thank all of you who participated in this webinar. And this is just the beginning of our celebration of vaccines as part of World Immunization Week. So thanks to all of you for joining us.